This program is brought to you by Stanford University.
So today what I'm going to try to do is share with you the minimally invasive cardiac surgery that's done not only throughout the country but also here at Stanford. And I think sort of the obvious first question is, why make cardiac surgery minimally invasive? We know that traditionally what we do with all cardiac surgery has always been to make an incision down the center of the chest. You feel the breastbone just underneath there, and we divide that, and the heart sits just underneath. And to do heart surgery, one of the benefits was to put them on what's called the heart-lung machine. And what that allows you to do is to stop the heart from beating, and you can operate in a still bloodless field. And patients have done very well from this. This is very well established, and the risks are very low. So you might ask, well, then why change something that's working so well? And so minimally invasive heart surgery has obvious benefits as listed here. We're seeing that patients are getting older and older, and they have more and more comorbidities or medical problems. A lot of these patients have renal disease, hypertension. They might have a bad heart from previous heart attacks. And so minimally invasive heart surgery, we feel, will really help these patients. One, if you have a smaller incision, patients like the cosmesis of that. It's very small, it's less painful. If these procedures are less painful, that means patients can take deeper breaths, get off the ventilators quicker, and ultimately that means that patients will get home quicker. So what are some of the minimally invasive techniques being done or developed recently? We'll talk a little bit about coronary artery disease with bypass surgery and how that's being done more minimally invasively. We'll spend some time talking about valvular heart disease, and we're currently doing an exciting percutaneous aortic valve trial now at Stanford. People are doing minimally invasive techniques for patients with end-stage heart disease. So assist devices are becoming smaller and smaller. We will spend some time talking about thoracic aortic disease, looking at how you can treat aneurysms, dissections, using a small incision in the groin and putting stent grafts in. We're doing minimally invasive surgery for arrhythmias, particularly atrial fibrillation, where now you can just make small port sites and convert these patients back to a sinus rhythm. And at Stanford, we're doing some minimally invasive techniques for congenital heart disease, specifically atrial septal defects, where you can now use devices to close the defects depending on the patient's architecture. So what I'm going to sort of focus on today are the three things listed here, looking at bypass surgery, particularly aortic valve disease, and thoracic aortic disease. So I sort of show this picture here illustrating in the center is sort of the old cardiac surgeon who really uses all open technique. And we feel at Stanford that now you really have to be the cardiovascular specialist. So not only are you going to have to be able to do the open operation, but you have to do some more of these minimally invasive techniques. You have to be able to go to the cath lab and put in stents. You're going to have to know how to use robotic techniques. And we feel so strongly about this that we're actually the first program in the country to change the curriculum, how to train heart surgeons for tomorrow. And currently we're teaching them how to do these minimally invasive techniques, how to gain wire skills early so that our graduating residents will be able to do everything. So let's start by looking at bypass surgery. Is there just a pointer or no? Okay, that's fine. So sort of listed here, or a picture shown here, is the heart. This is the big blood vessel that comes off the heart. It's called the aorta. There's three main blood vessels that supply the heart. This is the right coronary artery. This is the left anterior descending artery, and to the left is the left circumflex. And as you know, with coronary artery disease, this is when you have a blockage or narrowing in the artery. Some of the clinical manifestations of this is having angina or chest pain. It might be with exertion or just while sitting watching TV. And if this occludes acutely, this can lead to a myocardial infarction, or what's otherwise known as a heart attack. And so the cardiologists have been excellent in developing over the years new techniques to do angioplasty, which is very minimally invasive. You just go through the groin, through the femoral artery, and you can open up these blockages with tiny little balloons, and now you can put stents in them that elute drugs to prevent these blockages from coming back. So then you might ask, well, when would you do open heart surgery? Obviously, patients would always rather have a small stent than going through a big operation. And so now we're doing primarily these bypass procedures for patients who aren't candidates for stents. So these are patients with occluded vessels. And then patients who tend to have multi-vessel disease, especially if the patient has diabetes. And then finally in patients with left main disease. And so because patients rather have angioplasty, we've had to come up with other techniques to make bypass surgery more minimally invasive. And the first panel here is listed as OPCAB, and this is the off-pump coronary bypass surgery. And so as I mentioned earlier, we traditionally used to put people on the heart-lung machine. And it's really the heart-lung machine that patients have some effects from, meaning that sometimes they have to be on the ventilator longer, sometimes it can affect your kidneys, in particular in patients with kidney disease. And so this is really a benefit. We don't use the heart-lung machine at all. The heart's beating. We use stabilizers and just sew directly on that portion of the heart, the bypass. There's been a number of studies on this and have shown that patients get out of the hospital sooner and there's less blood loss and transfusions. But you might ask, well, you still have to have a big incision. Is there anything more minimally invasive? And so particularly in the West Coast, there's one institution that's now doing this robotically and completely thoracoscopically, where there's just going to be these tiny little port sites, which is illustrated here. So there'll be no more sternal incision. We'll just make tiny little port sites, and using a robot and putting ports in that you can put a camera in and do this completely with the chest closed. So this is sort of where we're going for bypass surgery that we really think will benefit patients. Some of the things that are allowing us to do this are devices like this. This is called a passport, and traditionally we've always had to hand sew a bypass, for example, from the aorta to the coronary artery just past the blockage. And now there's these fancy devices that will be able to go through a small port site that will automatically sew it on for us. And it's with instruments like this that will really advance the field. So let's move on then to aortic valve surgery. So on the previous cartoon, we showed you the different blood vessels that supplied the heart. Illustrated in this picture here are the 4 valves of the heart. So you can see here on the right side is the tricuspid valve. It then goes through the pulmonic valve to the lungs where the blood gets oxygenated, and then comes back to the left side of the heart through the left atrium to the mitral valve, and then out here, which is called the aortic valve. And that's a one-way valve that then goes up the aorta and gives the blood to the rest of the body, so to your brain, your arms, your intestines, your legs. And this is one of the most common valves that can get calcified or stenotic or blocked over time. Often patients will be told that they have a heart murmur, and this is one of the more common ones. Through the years, the etiology of aortic stenosis has changed. It used to be due primarily to rheumatic disease, but now that this has been treated more aggressively with antibiotics, the most common cause of aortic stenosis or blockage of the aortic valve is just what comes with age. There is a particular group of patients that's listed here as congenital that are born with two cusps of the aortic valve. Normally there are three, and while this is a variant of it, these for some reason tend to calcify early. And so patients who are less than 70 years old who show up with significant blockage of that aortic valve tend to have this bicuspid valve, and many times people don't know they have it. So this slide here is just to sort of remind myself. So you might ask, well, you know, if I have aortic stenosis, do I have to have surgery? And the answer is no. The patients that we know should go directly to have an operation are those who are having symptoms from it. Those symptoms would be chest pain, shortness of breath, dizziness, or fainting. We know that once you start to have actual symptoms from aortic stenosis, that patients do not live very long. Within 1 year, it's a 38% mortality rate. So these are very risky patients that need to be operated on. However, despite knowing that patients with severe aortic stenosis often, might die within a year or certainly within 5 years, often aren't referred for surgery. And you might ask, well, why is that? And this slide kind of shows this. About 50% of the patients don't even make it to a referral to surgeons because they're thought to be too sick. Often these patients are older, they're in their 80s to 90s, they might have kidney disease, they might have emphysema from smoking, and so a lot of primary care doctors won't refer them to the surgeon because they don't think the surgeon would want to operate on them. And often, especially with our traditional technique, that's true. And so that's why I want to spend a little bit of time telling you about our exciting trial using the percutaneous aortic valve replacement, which is truly minimally invasive. First, let me compare this so you can really see how minimally invasive the percutaneous valve is. Let me show you what we do for the open technique. We do try to make this more minimally invasive by just doing a minimal or mini sternotomy. You can see here that it just goes through the first 3 ribs, where traditionally we go through all of them, or I should say the sternum. This allows us, this picture here shows the aorta. We'll just make a small incision in the aorta, and this will expose the aortic valve. This is usually very calcified. Illustrated here is a trileaflet aortic valve. We excise that valve, put in sutures, and sew in what's illustrated here. In this case, it's a biological valve. Sometimes it's a valve from a pig or made out of the lining from a cow. We close up the aorta, and you can see that really it's just a small incision and with some drainage tubes. Importantly for this operation, it does require us to put the patient on the heart-lung machine to stop the heart from beating, sew in the new valve, and then get the heart to start up again. What's truly been an incredible technique, and really just over the last, I would say, year or two, are the use of percutaneous aortic valves. One of the benefits is that this will definitely be an option for patients who are very high risk, who have the bad lungs, who wouldn't do well on the heart-lung machine. Or you can even imagine if someone has emphysema and you have to do a big sternal incision, it's hard for them to breathe afterwards. So this will be another option for those type of patients. Again, it's totally percutaneous. I'll show you it's a very small incision in the groin. You can get completely rid of the cardiopulmonary bypass machine. There's less complications, less stroke, less heart attacks. There's definitely less pain. You don't have the sternal incision, and we hope that these patients will be discharged home quicker. One of the neat things, part of this trial, that's called the partner trial, is that this is a combination that all of these procedures are done with 2 surgeons and 2 cardiologists, and it's truly a team effort. We see these patients together, we identify the patients, and then we'll do the actual procedure together. This is a picture of the valve here. This valve, I'll show you in a couple of pictures, can actually be crimped down to be put on a balloon. The stent that you see on the outside is a stainless steel stent that when it's on the balloon, you blow up the balloon and it can expand. And inside are bovine pericardial tissue valves. These have been put in for about almost 2 years now. In Europe, there's been over 2,000 placed, and here in the United States, there's been about 600, and so far they've done very well. This can be put in 2 methods. Over here is transfemoral, which means we expose the femoral artery in the groin and put it up through that artery. And we won't talk too much about it today, but in some patients, when their vessels are too small, we can make just a small left anterior thoracotomy, which is an incision just to the underneath the breast, and you can go directly through the heart to apex. So how do we do this? So what we do is expose the groin vessel, the femoral artery. What we do is put a balloon up. So this is similar to if you have an angioplasty done. So we have a catheter that goes up the artery in the leg, goes up the aorta through the aortic arch. Here's where this calcified aortic valve is, and the first step is to put a balloon across that tight valve, expand it, and really open up that calcified valve. Then what you do is you switch out your catheter, and you can see here is the crimped down balloon with the stent that's onto the balloon applicator itself. You blow up the balloon, and that expands the valve, and it's held into place. And you don't actually cut out the old calcified valve leaflets. Those are spread apart, and then that's what helps hold the new valve in place. And here's sort of a cartoon that shows this a little bit better. So it shows going up with the wire, going what we say retrograde, going across the transverse arch. Here's your calcified valve. Now you're going to have a balloon go across the valve. You blow that up, and that does a valvuloplasty, makes that opening bigger. And then now here's your balloon with the crimped down valve on it. You blow up the balloon, and that expands the aortic valve, and that's it. So there's no big incision, no bypass. These patients, we just closed a small groin incision. We take the breathing tube out in the cath lab. It's really incredible. They stay maybe a day in the ICU. No heart-lung machine. So this is an example of a patient who we did about a week ago. You might ask, so who are these patients who get this? So importantly, it's still a trial that's going on in the United States. This is by a company called Edwards, who make both the valves that you sew in as well as obviously these. And there's 22 centers in the United States who are currently doing it. In California, it's only Stanford and Cedars in Los Angeles. And it's really it's an incredible trial. It's very well organized. Every Thursday, there's strict criteria to get into this. So you only can be very high operative risk. So if you were a 40-year-old person who needed a valve and everything else was good, your kidneys were fine, your lungs were fine, you actually couldn't qualify for this yet. It'll probably be available to the public, I would guess, in about 2 years. But so this is a patient who's 93 years old and was on home oxygen, very bad lungs, had diabetes, bad kidneys, and so nobody would ever think about doing an open heart surgery on that patient. Where this valve really has changed his life, and within really in a week, how strong his heart could squeeze was double than before the surgery. And so this is sort of a picture here. It's a CAT scan. It's a 3D image. Here's the heart, and here's this white block or rock there. That's the aortic valve, and so the white is where it's calcified. And so that's the calcified valve. This is an example of an echo, and so what we do is look at the architecture. Again, the white is calcium. So this is a calcified trileaflet aortic valve, and what we do is measure the annulus to figure out what size valve to put into them. This is another CAT scan looking at the blood vessels in the legs, because we have to expose that artery, and the vessels have to be big enough to fit the sheath to get the valve up. And so this is similar to the cartoon. This is the valve here that's on the balloon. It's still crimped down. It's a little bit difficult to see, but this is the calcium, and the valve's already in place, and this is just where we'll blow up the balloon and seat the valve. So you can see the balloon expands, the valve is expanded, and it is held in place by the calcium of the old valve leaflets. So next I'm going to move on then to what we're doing for thoracic aortic surgery, the minimally invasive approaches. You might ask, well, what sort of things, what does that mean, thoracic aortic surgery? What sort of diseases do you treat? We'll talk a little bit about dissections, which is a tear in the aorta. We'll talk about aneurysms, which is sort of the ballooning or dilatation of the aortic wall. And then we'll spend just a couple of minutes talking about traumatic aortic transections. So first let's start by talking about aneurysms. I think most people sort of always mix up the term aneurysm and dissection. And so an aneurysm is a local dilatation in the aorta. The aorta is divided into multiple parts. The first part that comes off the heart is called the ascending aorta. It goes into the transverse arch, and then the descending aorta. The descending aorta is in the left chest. The most common location for these aneurysms is in the descending aorta, although they can occur anywhere. And just by definition, the dilatation has to be about 1.5 times the normal, your own normal aortic size before we call it an aneurysm. So who are the people who get aneurysms? Some come from just atherosclerosis with old age. Some patients have connective tissue disorders. That would be someone with like Marfan syndrome whose tissue is weak and allows the wall to dilatate. Patients with dissections, you can imagine that if you have a dissection, that wall where there's a tear is weak, and so if you have high blood pressure, it'll eventually allow that aorta to dilate. Some patients have infections, or patients have inflammation. It's called a vasculitis. All of those will lead to aneurysm formation. Now, traditionally, we fixed aneurysms with open techniques. And the open techniques to fix an aneurysm definitely is not minimally invasive. And we still do these today because there are certain patients that you can't do what I'm going to illustrate as a stent graft. But to do these surgeries, you have to make an incision, sometimes from the back all the way to the front over the abdomen. It's a very big incision, and while these operations are necessary, they do have risk to them. And so this slide here illustrates a big dilated aneurysm. The reason to do this is that as they get bigger and bigger, then they can actually leak or rupture. So on the left-hand side, you can see that what you have to do is replace this whole aneurysmal aorta. You actually open it up, excise it, and put in a synthetic aorta, which it's called Dacron. It's sort of like a pant leg, and it's permanent. And if you have to replace aortic tissue that starts to go down to branches, for example, branches that go to your kidneys or your intestines, then you have to reimplant all these. And so these can be very long operations. Some of them can take, 6 hours. Sometimes if you have to replace the whole aorta, up to like 10 hours. So I believe it was in 1996 at Stanford, taking some of the techniques that people have used for the abdominal aorta, was developed stent grafts to use for the thoracic aorta. So similarly to what I was showing you for the percutaneous aortic valves, you can just make a small incision in the groin, expose the femoral artery, and you put a sheath in there, and then through this sheath you can put what's called an endovascular stent graft. So this is a stent that goes inside the blood vessel, and you put the stent from normal aorta to normal aorta, and this will exclude that aneurysmal section. That means that aneurysmal area will not see the pressure, your blood pressure, and so that'll prevent it from either getting bigger or rupturing. And here's a picture of that just in cartoon. You can see the stent is opened up. It excludes or takes away the blood flow from this area. Instead, it'll just go directly down the tube of the stent graft. This is an example of a stent graft we use at Stanford. It's called the Gore tag device. This is a PTFE graft, which is similar to the Dacron grafts I was showing you for the open technique, and it has a nitinol exoskeleton to give it body and strength. And you can see on the left, it's on a catheter device. You just put it up, pull a string, and it illustrates here that the graft will open from the center and then expand. And this will then just allow the blood flow to go through the actual stent graft. This shows the incision in your groin. We pick usually the side that has the bigger blood vessel that we can see on the CAT scan. And this is an example. This is an X-ray. Again, this is the ascending aorta, transverse arch, descending aorta. You can see this large aneurysm, and then over here on the left-hand side, I don't know if you can make it out, but you'll see sort of these cage-like structures. This is the stent graft within the actual blood vessel, and you can see that it excludes that aneurysm. So again, this takes it from a big incision, long operation. To do many of these procedures, you actually have to collapse one side of the lung. We're turning it into just doing a small incision in the groin, putting in the stent graft. Many of these patients are just extubated in the operating room. This is a CT scan showing the same person. This is sort of a slice going through your body. This is the heart here. This is the ascending aorta. This is the descending aorta with the big aneurysm. In this case, the contrast shows up white, which would be equivalent to blood or the flow of blood. And then you can see here's again the ascending aorta. Here's this big aneurysm, and then here's the stent graft. You can see the blood flow is only going through the stent graft, where this aneurysm is now excluded from seeing any blood flow or blood pressure. So this will end up just becoming clot, and it'll just stay that same size. And we tend to monitor these patients more frequently the first year, and then usually they'll get annual scans just to make sure that there's never any leak in these. That, you know, occasionally what can happen, they're called endoleaks, and sometimes over time, particularly if you have to put 2 stent grafts, if it's a long area, these stent grafts over time can get a little leak in between those zones that you overlap, and so we'll be looking for that. But usually these will clot off and you won't see anything. The next thing that we do use them for are dissections. So in contrast to previously, an aneurysm was where you had a dilatation, sort of like a water balloon, getting bigger and bigger. In contrast, the dissection is when you actually have a tear in the aorta. Listed on the picture on the top is Patrick Daly in 1970 at Stanford. He came up with what we call the Stanford classification. And most people throughout the country use this, I would even say across the world, because it's so simple. Basically, we break it down to 2 types. A type A dissection is when the tear involves this ascending aorta, where a type B dissection is when it involves the descending aorta. And why is this important? Because the treatments are different. For a type A dissection, that's a surgical emergency. There's no minimally invasive technique for that. That's someone who you go straight to the operating room, whether it's 6 in the morning or 2 in the morning. I think a lot of people know more about this because of John Ritter. If you remember, John Ritter is one of the actors from Three's Company. And so it was probably a couple of years ago, he had a type A dissection, and he ended up dying before they could get him to the operating room. And so this is a true surgical emergency, that if you don't operate on them, for every hour that goes by, it's another % chance of dying. Where we can use more minimally invasive techniques is for the type B dissection. Just to show you sort of the pathophysiology of this, so dissection is when you actually have a tear in the aortic wall. And what this allows is you to have blood flow in between the media and adventitia. And there's 3 layers to the heart. And so before, where you just had the dilatation of the aorta, or sort of like a water balloon expanding, now in this case, the aorta is not necessarily bigger, but you have a tear that then allows blood flow in those 2 lumens. And you can imagine that if you have high pressure that's now going through this wall that's torn, that's a very thin, delicate wall, these patients can rupture, and if they rupture, they would obviously not make it. So what is the treatment for these? Well, as I said before, a type A dissection, you operate. Now, for a type B dissection, you don't have to operate every time. We only operate if there's some sort of complication. So patients who are having pain, we use this as an indication that they might have already ruptured and it's contained, or they have impending rupture. Sometimes these dissections will tear into the blood vessels, so let's say supplying the kidneys, or the blood vessel go into your leg. And if you're not getting good blood supply there, those are the patients you have to operate on. Otherwise, if somebody comes in and they don't have any complication from it, then we just treat it medically, which means just giving them good blood pressure control. So traditionally, what we did was open surgery. Again, that requires the big incision from the back towards the front. And we still actually will say we should do this operation, in particular patients who are very young or are very good operative candidates. And the reason behind this is that when we do the open technique, we know that somebody who's, for example, have a connective tissue disorder and they're only 20 years old, you want to do a technique that's going to be permanent and it's going to last them for their whole life. And so that you can do with the open technique, where you actually replace that whole aorta. These endovascular techniques, they're relatively new, and so far we don't know how long they're going to last. Additionally, in some of these patients who have very weak aortas, we don't necessarily want to put in a stent graft because we worry that if the aortic wall is so delicate, could it cause more injury to the wall? But in particular, patients who are older, patients, again, who have bad lungs, or if people come in very sick, you can imagine if they have bad blood flow to their intestines, they can be very sick. And so those aren't people you want to rush to the operating room. And so if you can put a stent graft in, get them through the sick period, then you could either watch them carefully or do the open procedure electively. So just to give you an example, again, this is the non-minimally invasive technique. Again, this is the big incision that goes from the back to the front. You expose the aorta. You find where the tear is, and you excise that portion of the aorta. Again, here's the synthetic aorta, or the Dacron graft. And that's the proximal anastomosis. You get rid of that torn aorta. And then what this does is it redirects your blood flow and improve all the flow to your, for example, kidneys or your leg that was cut off from the dissection. So how about the minimally invasive technique? This shows a patient that had the stent graft. This is, again, a 3D image. This illustrates the most common area where these dissections occur are right past the blood vessel called the left subclavian that goes to your left arm. And so usually we'll put these stent grafts just past that. So this is a patient that we did about a week ago. It was a 58-year-old male. The most common symptom from a dissection is acute chest or back pain. And this patient was just sitting watching TV and had severe back pain, didn't go away. and he eventually went to the emergency room. His leg was cold on one side, and he had a very tender belly, and his kidneys were involved as well. This is what these tears look like. So this is the aortic arch. Here's the subclavian artery. You can see this large tear. As you walk down, you can see there's two lumens with the tear in between. And over here, you can see where there's this very small lumen that's almost completely collapsed. That's the lumen that all the branches to his intestines and his kidneys were coming off of there. And so you can imagine if the blood flow is sort of squished, then those organs aren't getting flow. And so we ended up, we brought him to the cath lab. Here's where the tear is. We put a stent graft in there and closed off that tear. And this restored all the blood flow to his organs. So I'll go ahead and end with aortic trauma, and again using the stent grafts in this case. Now, after motor vehicle accidents, a lot of patients will have such severe force that you can imagine if you get hit, the impact can cause a tear in the aorta, in particularly in the areas where it's held in certain places, and that'll cause sort of a shearing and can tear the actual adventitia of the aorta. We actually don't know how common this is because many people don't make it to the hospital. Only about 20% of the patients with aortic tears will actually make it to the hospital, and then even when they get there, the mortality rate is extremely high. Often you might ask why people die at the scene of an accident, and the majority of them are from traumatic aortic injuries. It used to be that whenever we had a patient that would come with a traumatic aortic injury, it was a patient that you just took directly to the operating room and we repaired the aorta. And then we soon found out that those patients didn't do well. You can imagine that if the force is enough to actually cause a tear in the aorta, these patients would have other associated injuries. And so they would have injuries to their liver, to their spleen, and to do all these operations, we have to put them on the heart-lung machine, which requires a blood thinner. And so you wouldn't want to give somebody a blood thinner if they also have bleeding from their liver. And so what we learned over time is that really what you should do is fix the other injuries first, and then next would be to repair the aorta. And even now we're starting to learn that some of these patients, if they're hemodynamically stable, meaning their blood pressure is fine, their heart rate's fine, that you can actually watch them a little bit and then electively repair these, whether it's with open technique or by putting these stent grafts in. So this is an example of a patient with an aortic injury. And you can see sort of this mushroom here. This is a tear in the aorta, and it's really just the surrounding tissue or adventitia that's holding everything together. And just as an example, this was a 29-year-old gentleman. He was in a motor vehicle accident at high speed. He had multiple injuries. So he had a liver laceration, his spleen was ruptured, and so he was initially taken to the operating room by the trauma surgeons. And so they fixed all these injuries in his abdomen. And so you can imagine that despite knowing that he had this aortic injury, they didn't want us to take him then for a long operation to fix the aorta. And so what we did instead was to put in one of these stent grafts. This again shows the injury here. This is an angiogram. So we were able just to take him to the cath lab, put in the stent graft. This sort of shows the catheter going up. The stent graft is deployed. And again, this just keeps the blood within the stent graft itself, excludes that torn aorta, and doesn't require us to give any sort of blood thinner. In the case of a trauma, you can give very little or none. And these patients do quite well. So I'll go ahead and stop there and entertain any questions you have. And that's an excellent question, and the answer is yes. So it's pretty interesting because it's actually changing the way we're sort of recommending what sort of valve you should get. And so traditionally there's two types of valves. So there's the mechanical valve, which is almost like a metal valve. And so the benefit is that'll last you your whole life. The downside is, as you were mentioning, you have to be on a blood thinner called Coumadin. If not, the risk is that you can form little blood clots on the valve itself that then can break off, and if it went to your brain, then you would have a stroke. So the other alternative then is what we call a biological valve, which is what you have. So it's either like a pig valve or a cow's valve. And so the benefit is that you don't have to take the blood thinner. The downside is it won't last forever. And so, and it sort of depends on the patient's age as well as the location. Now, the aortic valve tends to last longer than if you replace any of the other valves. But you're right, and it sort of depends on the valve, but usually in the aortic position, it lasts about 15 to 20 years. And it turns out, it's interesting that as you get older, they tend to last longer. And so usually we recommend that, that patients around 60 or over get the biological valve. Now, if it's somebody who's young, we used to say you should get a mechanical valve, because otherwise, let's say if it's somebody who's 50, well, if it only lasts 15 years, that means at 65 they're going to need a second heart operation. And then say it lasts only another 15 years, then when they're 80, they're going to need a second or a third operation. And each time it's riskier. So those patients, we always said to get a biological valve. But what do you do then in somebody who's young, but let's say their age, a woman who wants to get pregnant? Well, you can't be on Coumadin for that. So then what do you do for those patients? Or some patients would say, because let's say you wanted to ride a motorcycle, or you're sort of a daredevil skier. Well, you have to be careful if you're on Coumadin, because if you fell and hit your head, then you're at increased risk of having a bleed around the brain. And so now we can sort of change our thinking, because what they're actually doing is we can put this valve inside your present valve. So we can treat it like a native valve. And so we're calling it a valve in a valve. And so what we'll be able to do for you now is go through the groin, just make a small incision, and do the exact same thing as if it was your own native valve. We will balloon, dilatate the stenotic prosthetic valve, and then put one directly inside of it. And so now, if you have somebody in particular, like someone who's trying to decide what to do, or say they're 55 and you're trying to think, well, should we give them the biological one versus the mechanical? So now we're telling people, no, I would definitely go with the biological, because by the time that your valve fails, this will be prime time, and we'll definitely be able to put it inside your other one. They've only been putting them in for a couple of years, and so the long-term data isn't out there yet. And so far, the year data has come out, and there hasn't been any deterioration, but we still have to see that and wait for the long-term data. And that's part of the reason also why currently, for a trial, that they'll only put it in very high-risk patients, because we know that the traditional technique works and they last for a long time. And so that's why for the trial, it's only in patients who are very high risk or otherwise non-operative candidates. It did get a lot of attention, and we were actually curious as heart surgeons if it was going to sort of sway now whether people would be afraid of the coronary stents and go back to saying, well, I'd rather have the traditional bypass surgery. But when you actually looked at the data, and the interventional cardiologists know this data better than I do, but it's still such a small percent of a chance that it really, I can't even quote the numbers, but it's like less than 0.5% or something like that. So it's a very small risk, although they did see that you can get what's called stent thrombosis, or you still can get, basically clogging of that stent. And that's sort of why people used to be hesitant to put a stent in the left main coronary artery, because the left main, as I told you, there were 3 blood vessels to the heart, and the left main branches into 2 of those, so it's sort of like the water main. And so if you shut off the water main, then you knock off 2 blood vessels. And so people used to be a little bit nervous putting in the stent in the left main because you would affect so much territory of the heart. And so traditionally, if you had a left main disease, those patients went to bypass surgery. But there are some studies coming out that are looking whether you should stent those or not. People have looked at that and sort of compared through the years stents versus bypass, where if you just have 1 blockage, 2 blockages, 3 blockages. And some of that data is sort of, while they're good studies, they're not entirely pertinent because techniques have changed so much. So a lot of the data has come for before they had drug-eluting stents. And we now know that the drug-eluting stents will prevent this restenosis within the stent. The other thing is what's sort of changed from the bypass surgery is we now know that if you bypass using an artery, it stays open longer. And so now it's standard that we use arteries. And unfortunately, all these studies were sort of before we had the great techniques. But nonetheless, if patients have 1 or 2 vessels, as long as your anatomy will allow it, we'll often still get 2 stents. Now we know the patients who do best with bypass surgery are when you have 3-vessel disease, and in particular if you have diabetes. And we know that if you follow these patients long term, that those patients live longer and their grafts stay open longer when they have that severe disease. It's sort of in the middle of the study. So like at some of these meetings, like the American Heart Association meetings, they're starting to present some of the data, and some of the early stuff is you can look up, in journals, but it's so early and they're still collecting all the data that's not been really released yet. Okay, thank you very much.